So it's my pleasure to introduce Dr. Graham Nichol to speak at Medicine Grand Rounds this morning. Dr. Nichol is a professor of medicine in the Division of General Internal Medicine and Leonard A. Cobb Medic One Foundation Endowed Chair in Pre-Hospital Emergency Care. He also serves as director of the UW Harborview Center for Pre-Hospital Emergency Care and medical director for the Resuscitation Outcome Consortium Clinical Trial Center. Dr. Nichol earned his medical degree and completed his house staff training at the University of Western Ontario. This was followed by research fellowships in clinical epidemiology at the Ottawa Civic Hospital and Brigham and Women's Hospital, where he concurrently obtained his master's degree in public health from Harvard. Dr. Nichol arrived at the University of Washington in 2004, at which time he was already a world-renowned investigator in pre-hospital care and out-of-hospital cardiac arrest. He has continued this work during his time on faculty, maintaining exceptional research funding and being very productive in terms of peer-reviewed publications with over 250 published manuscripts, including key national and international guidelines in pre-hospital resuscitation and out-of-hospital cardiac arrest. He is distinguished as a fellow of the American College of Physicians, the American Heart Association, the European Resuscitation Council, and Heart Rhythm Society. He has also received numerous accolades, including the Award of Meritorious Achievement for the American Heart Association in 2008. Please join me in welcoming Dr. Nichol as he presents Endovascular Resuscitation to Modify Reperfusion Injury.
Thanks very much, Brian. I think my strategy worked. If you give me a long introduction, I won't have much time to talk. I'll start with a story, actually. I work in the ED at Harborview clinically, and in the break room, we have a diagnostic algorithm which helps you determine whether you have flu. And the first question is, do you feel like you've been hit by a train? Yes. And the second question is, have you been hit by a train? No. Then you have the flu. And I've actually been home in bed for the last 2 days feeling as though I've been hit by a train, so I beg your indulgence. So these are my disclosures, including industry funding from Zoll Circulation as PI of their Cool STEMI trial. I'm going to continue telling stories by using the great medical reference, The Princess Bride, as a basis for my talk. And I'll begin by noting that The Princess Bride tells us to use evidence and to be open to new therapies because one of the characters, the king, becomes ill during the movie, and the new doctors all agreed on various tried and true medications, and within 48 hours of their coming on the case, the king was dead. So when local or focal or global ischemia occurs in the heart or brain or really in the rest of the body, timely restoration of flow is critical to survival, but there are a variety of cellular changes that are triggered by the act of restoring flow that are deleterious. These include release of reactive oxygen species, activation of cytokines, and culminate in opening of the mitochondrial permeability transition pore, which leads to cell death. Collectively, these changes are commonly known as reperfusion injury. And you are aware from prior studies that there's a belief that hypothermia modifies reperfusion injury. There's a debate about how much it does so. This is data from a large observational study in Spain where they looked at the relationship between a time to target temperature of less than 34 degrees and death or neurologic outcome 6 months after cardiac arrest. And they reported that time to target temperature was strongly associated with outcome. The only other variable that was more strongly associated with outcome was whether the person had a shockable rhythm. People subsequently have done randomized trials to look at the relationship between use of hypothermia and outcome. There has been a debate about the effectiveness of the therapy, in part because these trials used a neurologic outcome measure that is subjective. And you will recall from The Princess Bride, there's a big difference between mostly dead and all dead. Mostly dead is slightly alive. With all dead, well, with all dead, there's usually only one thing you can do, go through his clothes and look for loose change. So the prior trials were also criticized because in the Hakka trial, which I'll show you the results of in a minute, the control group that was allocated to normothermia was allowed to become febrile. during the follow-up period, and we know from multiple prior studies that fever is deleterious to the injured brain. Subsequently, investigators completed a subsequent trial known as the Target Temperature Management Trial. This shows the temperature over time in the mild hypothermia group allocated to 36 degrees and the moderate hypothermia group allocated to 33 degrees. Note that the horizontal axis is actually hours since randomization rather than hours since the onset of arrest. And so they took a long time to get to target temperature, and that may have impacted on outcome, which leads us to a summary of the prior trials of hypothermia. This is time to target temperature and outcome in randomized trials of hypothermia in adults resuscitated from out-of-hospital cardiac arrest and transported to hospital. The Bernard trial randomized patients unconscious after out-of-hospital VF to control or intervention. The intervention group was to achieve a target temperature of 33 degrees. It took them about 270 minutes to achieve that, and they observed an improved rate of survival to discharge. This was not significant on its own, but when they looked at neurologic outcome measured with the subjective measure which I referred to previously, it was beneficial in favor of the intervention. This is the Hakka trial published simultaneously. Again, unconscious adults resuscitated from out-of-hospital VF or pulseless VT, randomized to control versus intervention. The intervention group received a target of 32 to 34 degrees. It took them about 500 minutes to achieve the target temperature, and there was a significant difference in survival in favor of the intervention group. And then the Nielsen trial, or the TTM trial, randomized adults resuscitated from out-of-hospital PEA, VF, or witnessed asystole to control 36 degrees or intervention 33 degrees, and it took them more than 660 minutes or 11 hours to get close to the target temperature in the moderate hypothermia group, and they never actually achieved it, and there was no difference. So this led to a lot of people concluding that they did not need to initiate hypothermia, they did not need to get patients cold, in part because there were potential downsides of cooling to 33 degrees, including infection because cold white cells do not work as well, bleeding because cold clotting factors do not work as well, and electrolyte abnormalities because patients who are cooled have a cold diuresis. But in fact, there was no significant difference in the rate of infection or bleeding or electrolyte abnormalities observed in the two groups in the TTM trial. Now, prior trials of hypothermia in patients resuscitated from cardiac arrest generally excluded patients with cardiogenic shock. It's important to remember that greater cardiac power is strongly associated with lower mortality in patients with cardiogenic shock and acute infarction. And here is a case control study of patients cooled to 33 degrees with endovascular catheters versus those cooled to 35 degrees with surface methods. The point is not so much that the survival appeared to be different. The point is more that the patients who were cooled to 33 degrees had greater cardiac power output than those who were cooled to 35 degrees, primarily generated by differences in stroke volume. And so I don't think the presence of cardiogenic shock is really a contraindication to the use of hypothermia post-cardiac arrest. There's also a debate about how long patients should be cooled post-cardiac arrest. This is a moderate-sized randomized trial published last year in JAMA, where they compared hypothermia to 33 degrees for 24 hours versus 33 degrees for 48 hours. It was widely reported as negative, and in point of fact, there was an error in the primary publication. They reported the primary outcome of good neurologic status only in those who survived, whereas ordinarily you would include or report outcomes for everyone who is randomized rather than just those who survived. If you calculate the statistics correctly, there was still not a difference in favor of 48 hours of cooling, but it did look as though there was a trend in favor of prolonged cooling. Now, Francis Kim and colleagues previously did a randomized trial of chilled saline in the field after restoration of circulation. It did not improve survival, but let's sort of tease those outcomes out. Among patients with ventricular fibrillation, those who were allocated to standard care had a temperature of 36 degrees upon ED arrival, which was 1 degree different from those who received chilled saline. But the proportion of patients who had a temperature of 24 degrees or less at ED arrival was low in both groups. And there was no significant difference in survival. Among those without VF, standard care temperature at ED arrival was 36 degrees, with chilled saline 35 degrees. Again, there was there was a small proportion of patients who had a temperature of 34 degrees or less at ED arrival, and no significant difference in survival. Recall that coronary perfusion pressure is the difference between diastolic aortic pressure and the right atrial end diastolic pressure. And we know from a prior study by Norm Parody, where he instrumented patients without a hospital cardiac arrest in Detroit, that greater coronary perfusion pressure is associated with greater likelihood of resuscitation after cardiac arrest in humans. The patients who never achieved ROSC had a coronary perfusion pressure mean less than 10. The patients who achieved restoration of spontaneous circulation had a mean coronary perfusion pressure of 25. Here is a randomized trial in pigs with cardiac arrest, which suggests perhaps in part why chilled saline in the field during CPR does not improve outcomes. Dimitri Yiannopoulos randomized pigs to control, post-resuscitation cooling blankets and ice, intra-CPR volume load with chilled saline, intra-CPR volume load with chilled saline and a cooling blanket, or intra-CPR endovascular catheter-based cooling. Compared to the group that received intra-CPR volume load, the control group, or the group that had post-resuscitation cooling with a blanket, or post-resuscitation, intra-CPR endovascular catheter-based cooling achieved greater coronary perfusion pressure, and all groups had significantly greater restoration of circulation compared to the group that only received a volume load. So I think the two challenges with initiating cooling with chilled saline during CPR are that it reduces coronary perfusion pressure, which is deleterious, and does not achieve a target temperature of 34 degrees or less fast enough to impact on outcomes. Now, some people look at the prior trials of hypothermia in patients with cardiac arrest and note that to date we have only studied hypothermia in patients with ventricular fibrillation. However, there is a large rodent trial which informs this. By that, I do not mean rodents of unusual size. I mean a rat study of nearly 270 animals where folks in Michigan randomly allocated the rats to hypothermia immediately, hypothermia 1 hour after onset of resuscitation, 4 hours after the onset of resuscitation, 8 hours after the onset of resuscitation, or normothermia. And you will note that the horizontal axis is survival time in days, and the vertical axis is survival, and there's a nice dose response between the timing of initiation of hypothermia and outcome. earlier initiation of hypothermia is associated with better outcomes. So I am embarrassed enough to admit that when I was a medical student back in the dark ages, we were becoming informed of the benefits of fibrolytic therapy in patients with acute myocardial infarction. There was a lot of excitement when the GISSI trial was published because it was the first trial to show that fibrolytics were beneficial in patients with myocardial infarction. There was more excitement when the ISIS trial was published, which also showed that fibrolytics were beneficial in patients with acute myocardial infarction. But in fact, if we had done a cumulative meta-analysis, we would have been aware 15 or 20 years previously that fibrolytics were beneficial. And at the time when GISSI and ISIS were published, some people said, well, the benefits of lytics are only observed in patients with anterior myocardial infarction, therefore we should only be giving drugs to patients with an anterior infarct. In point of fact, most of the previous trials had not published or had not enrolled patients with an inferior infarct. And so the issue was lack of study rather than lack of effect. And I would submit to you that I think where we are now with the use of hypothermia in patients post-cardiac arrest is where we were back in the 1980s with fibrolytics in patients with myocardial infarction. It's the same physiology whether you are treating an anterior or inferior infarct. Lytics work in both groups. It just had not been studied at that time. I think it's the same physiology with resuscitation from ventricular fibrillation or PEA or asystole. It's just that we haven't studied hypothermia in patients with PEA or asystole. So there are a variety of methods of initiating cooling. Some are faster than others. This is a randomized trial from France where they randomly allocated patients to old methods of endovascular cooling with catheters to old methods of surface cooling, ice and fans, and they observed the time to good neurologic status was faster with endovascular temperature management than surface in patients resuscitated from cardiac arrest. But as I say, this was comparing older technology with both methods. So what about the currently available technology? This is a contemporary case control study that was just published this year, which compared cooling rates and outcomes in patients who received surface versus endovascular cooling. It's an observational study, so we can only observe associations rather than cause and effect. But the time to 34 degrees was significantly faster with endovascular temperature management as compared to surface. There was no DVT observed in the endovascular group or in the surface group, which has been a concern with the use of these catheters in these patients. And there was a significantly greater rate of survival in the endovascular group. So what do these technologies look like? At present, we have used these technologies to rewarm trauma patients for several years in the ED at Harborview. We recently switched to also using these technologies to cool patients post-cardiac arrest. In essence, these catheters come out of the box with the balloons all bunched up. It's similar to placing a triple lumen. The Solex goes in the subclavian or IJ and is capable of extracting about 150 watts. The Quattro goes in the femoral vein and is capable of extracting about 175 watts. The Solex has, in essence, a corkscrew, through which cold fluid is recirculated. It does not actually enter the blood, but it abuts the blood and has a large surface area to rapidly cool the patient. Similarly, the Quattro has 4 sausage-shaped balloons which fill with cold fluid to abut the blood and rapidly cool the patient, and it can also be used to give fluid suppressors. And then it is powered by a console which is attached to the catheter. So When the TTM trial was published, I had Nicholas Nielsen come and speak to folks here immediately after it was published. And when he was getting into the taxi to go to the airport after his visit, he made this off-the-cuff comment that about 3/4 of the patients enrolled in the trial received propofol, which I thought was interesting at the time because that wasn't our practice, and I wondered whether that might explain the lack of benefit observed in the trial. And it turns out that the authors of the TTM trial subsequently published a secondary analysis from the largest enrolling site where they looked at doses of propofol in the mild versus moderate hypothermia group, and they reported that the patients who were in the moderate hypothermia group, 33 degrees, received significantly more propofol than those who were allocated to the mild hypothermia group, 36 degrees, at the time that they achieved target temperature. So a careful read of the literature would lead you to understand that propofol has dose-dependent beneficial or harmful effects on the mitochondria. Recall that I told you at the beginning of my talk that opening of the mitochondrial permeability transition pore is the final common pathway of reperfusion injury. It turns out that at low doses, propofol decreases reactive oxygen species in the mitochondria, and at high doses, propofol depletes energy in the mitochondria. Perhaps that's not something that you want to do when the body has been depleted of energy due to lack of oxygen. And so propofol reduces the benefit of treatments intended to reduce reperfusion injury. As well, propofol is cytotoxic in a rat model of neurologic or neuronal injury. Different doses of propofol, as the dose of propofol increases, after 2 hours of exposure, cytotoxicity increases. And again, with 4 hours exposure, as the dose of propofol increases, the cytotoxicity increases. Now, propofol is obviously widely used as an anesthetic agent. Why might it be cytotoxic in the setting of neuronal injury when it's safe in patients undergoing general anesthesia? I think the issue is in patients who are undergoing general anesthesia, they are generally healthy, they are not energy depleted, so it is not an issue. But I think in patients who have had ischemia or injury, it is a cause for concern. Here is another animal study. Propofol infusion increases the lesion size in an adult model, in an adult mouse model of traumatic brain injury. Here the mouse received saline, a vehicle, or propofol, and these are transections of the brain, and you will observe that when propofol was administered 24 hours after traumatic brain injury, there was a significantly greater lesion or injury to the traumatic brain. Then in patients who were randomized to general anesthesia with propofol versus sevoflurane when they're undergoing coronary artery bypass grafting, which has elements of ischemia reperfusion similar to cardiac arrest or STEMI. 13 trials randomly allocated 700 patients. The sevoflurane group, as compared to the propofol group, had significantly lower troponin index and measure of myocardial damage and less myocardial ischemia. So instead of using propofol for sedation or shivering control in patients undergoing hypothermia, I think we need to use alternative measures. What are we currently using at Harborview? We use skin counterwarming to reduce shivering. On first blush, this is counterintuitive because we are trying to cool the patient's body to protect their heart and brain, but the shivering receptors are in the skin rather than the core. So this is a multi-phase study where patients undergoing therapeutic hypothermia received skin counterwarming with an air circulating blanket to trick the shivering receptors versus no skin counterwarming. And you will observe that the resting energy expenditure increased with no skin counterwarming, and the shivering increased with no skin counterwarming. And then when skin counterwarming was replaced, the resting energy expenditure decreased. As well, magnesium decreases the shivering in normal volunteers. So there are multiple drugs we can use to avoid shivering apart from propofol. So let me explain. No, there's too much, so I'll just summarize. I think at this stage, all unconscious adults with spontaneous circulation after cardiac arrest should undergo whole body hypothermia to 34 degrees or less, regardless of the initial rhythm or the presence or absence of cardiogenic shock, without a volume load of chilled saline for at least 24 hours, without propofol for sedation or shivering control. So I'm going to shift gears now and focus to work which I think is not ready for clinical application, but I think reinforces the role of hypothermia in cardiac arrest. I'm now going to discuss the role of hypothermia in patients with ST elevation myocardial infarction. So this is a randomized trial in a pig model of myocardial infarction. The pigs were randomized to 38 degrees or normothermia versus 35 degrees versus 32 degrees. You will observe along the top row infarct size, a large infarct in the 38-degree group, a smaller infarct size indicated by the yellow arrows in the 35-degree group, and then a much smaller infarct size in the group randomized to 32 degrees. You also may observe along the bottom row a difference in area at risk. Now, area at risk is the area of reversible and irreversible cell damage. Large in the normothermia group, smaller in the 35-degree group, and much smaller in the 32-degree group. So in pigs with myocardial infarction, it appears as though hypothermia may not only reduce infarct size, but may actually abort the infarct. And so this is a randomized trial that is currently being conducted in Europe with the next generation cooling catheters. Actually, the pilot has been completed, and I'll show you the results of that. The pivotal is ongoing. Again, it's a catheter which is inserted into a large vein, has a large surface area to exchange heat rapidly with the blood attached to a console. In contrast to the current generation technology, which is in use at Harborview, this technology cools at about 10 degrees an hour, extracts about 450 watts. And so in the pilot study, a small number of patients were randomized to hypothermia versus control. Opening the artery was deferred for 20 minutes, and the core temperature at reperfusion was 33.6 degrees, below 34 degrees. So in the intention to treat analysis, there was no significant difference in infarct size. It's a pilot study. It wasn't powered to detect a difference in infarct size. But in the per protocol analysis of patients who achieved a target temperature of 34 degrees or less before reperfusion, the median infarct in the control group was 24, and in the hypothermia group was 17. So there have been multiple randomized trials of hypothermia in patients with STEMI previously completed and reported. The overall infarct size in the control group was 19. Among those who were randomized to hypothermia and achieved a target temperature of 35 degrees before reperfusion, the infarct size was 17. And in those who achieved a target temperature of 35 degrees or less before reperfusion, the infarct size was 10. So would that sort of infarct size translate to improved clinical outcomes? This is a systematic review of infarct size measured by cardiac magnetic resonance imaging after primary PCI for STEMI. This is not from hypothermia trials, but I think it gives us some insight as to whether a reduced infarct size would reduce clinical outcomes. A 5% absolute increase in infarct size over LV mass is associated with a increased subsequent mortality. No difference in reinfarction, but also a increase in rehospitalization. So the thought is by focusing on reducing infarct size, we will decrease clinical events, and we will be able to demonstrate or evaluate the effect of hypothermia in patients with STEMI by enrolling far fewer patients, as opposed to conducting a randomized trial to detect a mortality difference. So where is this therapy at in the United States? So this is the STEMI COOL trial, which is currently underway in the United States. We are actually using the second generation future technology as opposed to the technology that's under evaluation in Europe. This is in bench testing able to cool at 15 degrees an hour and extract 750 watts. We are randomizing 600 patients in 50 sites in the US. The primary outcome of infarct size over LV mass by cardiac magnetic resonance imaging. We are not looking at infarct size over area at risk because we think that area at risk will be impacted by hypothermia, and that would underestimate the effect of hypothermia. We're enrolling patients with ST elevation and at least 2 adjacent anterior leads, randomizing them to hypothermia to 32 degrees versus standard care versus standard care alone, and the results will be available in late 2019. So I have a few more slides and then I will wrap up, and I would appreciate you holding your questions. So there are a variety of other endovascular therapies that are coming to clinical use in patients with reperfusion injury. Colleagues at Harborview, including Eileen Bulger and others, have made ECMO available to rapidly rewarm patients who have had hypothermic cardiac arrest. They've achieved dramatic results. I look forward to learning more about the utility of those interventions in a broader patient population. As well, the trauma surgeons for some time have been using Reboa catheters or resuscitative endovascular balloons to obstruct the aorta in patients with non-compressible hemorrhage. In essence, they float a catheter up the femoral aorta to the proximal up the femoral artery to the proximal aorta to inflate it, to increase proximal pressure and allow repair of the hemorrhage. It's relatively simple to insert this catheter. It makes sense that this may work in patients with more traditional cardiac arrest, and it turns out there are actually 9 animal studies which suggest that putting a catheter into the proximal aorta and inflating a balloon to increase pressure may be beneficial in patients with non-traumatic cardiac arrest. That currently is being piloted outside the Northwest by colleagues and collaborators. So to summarize, cardiac arrest and ST elevation myocardial infarction have common physiology of reperfusion injury. We need to cool to 34 degrees as soon as possible after resuscitation from cardiac arrest to reduce reperfusion injury. Use of hypothermia in patients with ST elevation myocardial infarction is investigational but promising. And I think there are other endovascular therapies on the horizon to reduce reperfusion injury. So I'll stop there by noting that the field of endovascular resuscitation is rapidly evolving. The second endovascular management conference will be held in Sweden in June of this year. And I think this is a rapidly evolving field, and I think it is very promising approach to improving outcomes for our patients. I'll stop there, and I'd be happy to take any questions or comments.
Any questions for Dr. Nichol?
making the lower body hypoperfused by using the aortic catheter would seem to be going in the wrong direction in terms of cell injury and release of toxins.
So the question is perpetuating the low perfusion to the rest of the body going in the wrong direction? That's an interesting question. I don't think we know the role of Reboa in patients with non-traumatic cardiac arrest. I don't think it's ready for clinical use. There are people who are working on combining the balloon with adjuvant supersaturated oxygen or blood. I think it's an evolving space. I don't mean to promote something which is not ready for prime time.
Other questions? Okay. Thank you, Dr. Nichol.